Hi, my name is Andrea Escalante, and I am an internal medicine resident at Broward Health Medical Center. I'm excited to present an unusual case of dyspepsia secondary to a gastric hyperplastic polyp with xanthomatous changes. Gastric hyperplastic polyps, GHPs, account for the majority of gastric polyps and are often discovered incidentally during EGDs, with a prevalence of 2 to 6%. While typically asymptomatic, GHPs can sometimes cause symptoms related to intermittent gastric outlet obstruction. Various risk factors for GHP include Helicobacter pylori infection, chronic atrophic gastritis, and autoimmune gastritis. We present a case of a 36-year-old female with no past medical history who presented to the gastroenterology clinic complaining of abdominal discomfort, bloating, and early satiety for several months. Symptoms were episodic, typically postprandial, and with frequent eruptions. Prior workup by her primary care provider was negative for Helicobacter pylori infection and celiac disease. All her other laboratory exams were within normal limits. Due to the persistent symptoms and lack of objective findings, an EGD was recommended for further evaluation. During the EGD, a 1.2 centimeter pedunculated polyp with a yellow-white broad-based stalk was visualized in front of the pylorus of the stomach. The polyp moved in and out of the pyloric channel, causing a transient gastric outlet obstruction. Biopsies were obtained and histological examinations confirmed the GHP with xanthomatous change diagnosis. The polyp was endoscopically removed via snare polypectomy, and the patient reported a complete resolution of her symptoms. The prevalence of dyspepsia is on the rise, becoming one of the primary reasons why patients seek the advice of a gastroenterologist. According to a review article published in the Journal of Gastroenterology and Hepatology, functional dyspepsia accounts for most cases of chronic dyspepsia. This case presents a patient who required further investigation after failing first-line treatment for presumed functional dyspepsia. While gastric hyperplastic polyps are typically asymptomatic and discovered incidentally during EGDs, the specific characteristics of this patient's polyp, its location, size, and pedunculated nature, contributed to a transient mechanical obstruction in the gastric pyloric outlet. Gastric outlet obstructions can be a consequence of a wide range of pathologies. Thus, nonspecific symptoms commonly require further evaluation. In this case, a complete removal of the mass by endoscopy snare polypectomy led to a full resolution of the patient's symptoms. Unique to this case is the rare finding of a GHP with xanthomatous changes. The etiology of these changes observed in a gastric polyp remains unknown. However, current understanding suggests that such alterations may arise as a consequence of inflammatory responses or the aging process of the gastric mucosa. Hyperplastic polyps account for 70 to 90% of all gastric epithelial polyps. However, there has been fewer than 10 cases of GHPs with xanthomatous changes reported on PubMed database to date. During our patient's EGD, the grossly atypical nature of the GHP with yellow discoloration halted consideration for initial polypectomy as there was concern for possible malignancy. Once malignancy was excluded by histology, a complete polypectomy on repeat endoscopy was performed. In conclusion, structural causes of dyspepsia are rare, and this case highlights the importance of considering GHPs as a potential cause of dyspepsia, especially when a large pedunculated polyp is present. Endoscopic removal of GHP can effectively resolve symptoms and prevent potential complications. Definitive polypectomy of a symptomatic gastric polyp leads to a satisfying outcome for both physician and patients. This case illustrates one of the rare instances of a gastric hyperplastic polyp with extensive xanthomatous changes and highlights the importance of considering structural causes when evaluating patients with dyspepsia. Thank you for listening.